Oh, thank you. Let me click that too. So we can continue the ongoing discussion on developing action steps within our strategic plan on mobilizing health equity at the Mailman Center. So let's begin on reviewing the definition of health equity. So we're going to start addressing the first objective. And this first definition comes from the Robert Wood Johnson Foundation, where everyone has a fair and just opportunity to be as healthy as possible. And this requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So yes, we already know poverty and discrimination exist, but I appreciate this reminder that there are consequences, and that's where we want to focus. We want to address, and so we can remove the consequences. And what part do we play in attempting to remove the consequences and therefore all these obstacles? And then this definition, which is really equity in general, but I appreciated it, arose from a combination from maybe a past AUCD conference and information from the Developmental Disabilities Act of 2000, where equity is the absence of systematic disparities and unjust systemic policies and practices that unfairly disadvantage individuals with disabilities and their families, while unfairly advantaging individuals and family without such disabilities in the pursuit of what's needed to be fully productive and included and valued. And that's why I appreciate both of the definitions I demonstrated and wanted to illustrate here today. Now, of course, these are just words, right? So let's go to a visual, right? So I think hopefully everybody here may have seen a visual that looks like this, clarifying the difference between equality versus equity and versus justice and versus liberation. And it's all important, all very true, because we want to reach towards liberation. And that's great, right? And this is important. And then I also appreciate these two images on the right. Yes, they come from the Robert Wood Johnson Foundation, but I appreciate how inclusive and how realistic it can be on what we can do practically to change an environment. So that way we can move from equality, where everyone gets the same, regardless if it's really right or needed, versus equity, where everyone really gets what they need. Are we removing those barriers and those conditions that are blocking? I also appreciate these pictures on the right because of the variety of identities represented, which leads to the other term, and there's not a lot of terminology. I really wanted to focus on the two, which is really equity and intersectionality. And so this is important when we strive for equity in what we do day to day. And I appreciate Professor Crenshaw defining intersectionality as a lens. It's a lens through which you can see where power comes and collides, where it interlocks and it intersects. It's that overlapping of social categories for a compound experience of discrimination. And this is a reminder that each of us has our own unique experiences of discrimination and oppression. Therefore, we have to consider anything, everything, whatever can marginalize people. So that way we can better acknowledge and ground the differences among us, because that's the fight. This helps us towards the fight for justice. Published back in 2022, so not too long ago, right, last year, in pediatrics, and this was around care for autism. To have a Black, brown, and disabled body in the United States is to be connected to a history saturated in oppressive and discriminatory treatment. And this was addressing the intersectionality. And so though there's acknowledgement of roots of racism and ableism, combating the system that perpetuates them and all isms, that's where the work is needed. And that's where the drive towards mobilizing health equity will be important. So back in 2019, the Association on University Centers on Disabilities and some individuals with them worked together to develop an equity, diversity, and inclusion action plan. This was developed to assist UCEDS on eliminating disparities at the intersection of race, ethnicity, and disability. Can go further to immigration status, gender, age, can go to several. But this plan focused on addressing 3 global areas. My hope is I think you guys may have heard of this already before. Workforce diversity. So does the workforce reflect the diversity of the racial, ethnic, linguistic, and disability identities residing in the communities we serve? Cultural, linguistic, and linguistic competence. So is that ingrained in our activities across the core strategies of Mailman and every you said. And I'm sorry, when I say you said University Center of Excellence in Developmental Disabilities, and that's what we are, and local and state impact. So how are we using data or data, however, which way you want to word it or speak it, to illustrate the disparities experienced by our patients, families, and communities? Are we planning interventions utilizing this information? Are we collecting and interpreting data when assessing for outcomes from those interventions? And across all these three global areas are the two cross-cutting considerations that they wanted every institution to consider. Are we demonstrating participation of individuals with IDD and their families from marginalized backgrounds? And are we advancing knowledge in all these areas through research and scholarly work? When they developed this plan, they did an extensive review of the literature. And the literature was pretty clear, as we already know, that disparities exist with individuals from racial, ethnic, and linguistic backgrounds. We know this. We also know the literature is clear that disparities exist with individuals with intellectual, developmental, and motor disabilities. What's needed, but I also say what's growing, and we're making a lot of progress, I feel, are the disparities of individuals at the intersection of race, ethnicity, and disability, and others. So part of this literature review, and some of you may already know this, and we can and probably can go a little further, Latine, per this one study, and Black adults with IDD are already shown to have worse health outcomes than white adults without IDD. Also, than Latin and Black adults who also don't have IDD as well. And they controlled for income. They already controlled for other SES factors. Now, there is a need, of course, for further research, but we know it's been growing over the past decade for specifically certain mental health problems and those disparities among the IDD population. For example, suicide attempts have been higher, antenatal depression, and those with physical disabilities, comorbid depression has been on the rise as well. With early identification and intervention, back probably now over 10 to 15 years ago, the one study at age 24 months, Black children with developmental delays were 5 times less likely to receive services compared to white children. And in 2009, Mandel and his study showed that Black children were less likely to be diagnosed with autism by age 8 years. Fast forward, early 2020, it was February, the CDC report came out that those differences are starting to narrow, though they persist, when you do those comparisons, white versus Black children, as well as Hispanic children. Though they still persist, it is narrowing. At the same time, we also know a recent 2020 study later in the fall came out that the timing of the diagnosis is still delayed significantly, even when parents bring it up. And so we still have some work to do. The Constantino study is what I'm talking about in pediatrics. This is important because if you don't address disparities when they're young, right, these children grow up. So then disparities continue when they're in school, where we know there's an overrepresentation of minority students in special education classes. And there's, of course, we can go down the variety of ways of how they're diagnosed or missed, or even if they're diagnosed, are they receiving the right services or not, or are they appropriate to what it is? But we do know that Black students and American Indian students are receiving higher suspension rates for those who have IDD or receiving special education services. This influences post-secondary achievement, right, and career development, because again, if you don't address the disparities in school, these children continue to grow, right? And so then that leads to employment. There's a caveat to this, and after I finish the slide, I'm gonna bring it up, where we know Latine with adult onset disabilities are less likely to be employed 1 year after their injuries. And Black youth and Hispanic youth with IDD transitioning to adulthood have reported less financial independence and employment. But then if employed, based on the race and ethnicity, the type of job can differ. So what's interesting is I just came back from a conference where this was hit on. This actually became a plenary, and I appreciated that, where if we're not addressing those disparities, if these individuals actually aren't employed, the other concern is, and I'll be honest, are they going to prison? They're going in the wrong direction. So are our individuals from different races and ethnicities with disabilities, there's actually a school to prison nexus. And so that's a concern that we need to think about. And how is that helpful? What harm are we doing to these children and youth? And so that's what leads to the second objective in terms of how are we proposing how we want to address and mobilize health equity. So there are several organizations that have proposed different frameworks and curricula around health equity. And for today, I'm just highlighting one example. There can be several, and we can discuss which one is the better fit for us. But I'm going to highlight the Center for Disease Control and how they detail their foundation on training around health equity. So on the slide are the 6 domains on their guided training of health equity. And so I think for Mailman, these are the domains I think we hope to desire to achieve. So for the next couple slides, I want to focus on these 2. The establish and maintain infrastructure to advance equity and engage communities and mobilize partners to enable effective and sustainable organizational efforts. Because I think what's necessary for success with these, really all of them, but I'm hitting these and specifically the infrastructure, is the importance of data and how data is necessary to impact change, impact policy. And I appreciate Samantha Artiga touching on this from the Kaiser Family Foundation, that it's the cornerstone for efforts to addressing disparities. And it's essential, and measuring progress towards greater equity is necessary, because without it, inequities are going to remain unseen and really unaddressed, meaning we got to make sure we're hitting and targeting and addressing the right population, right concerns, so we can have the right result. And so how can we, Mailman, and how can we overall nationally use data to really advance health equity? And this is where I think it's going to lead to the next few slides of what I want to hit and then pause really to start a discussion. So various tools were mentioned and highlighted in terms of navigating data and addressing questions on health equity. So one example is the City Health Dashboard. You may have heard of it. It's a cool website to check out. They have a list of a variety of different metrics in terms of comparing where we are and the progress we're making, even by different cities. So for example, in Miami in 2018, we had an estimated average reading test score of 3.4 among public school 3rd graders, compared to the national average of 3 at the 3rd grade level. And so we were doing a little better than the national average, which is great. Miami had an estimated 77% of adults with a high school diploma. That's compared to the average of 87.9% across the rest of the cities that participate in the dashboard. And then Miami had an estimated 26.7% of public school students who were chronically absent in 2018, compared to the average of 18.3%. Then in 2021, I was just looking up other metrics. Miami had an estimated 27.8% of children in poverty, compared to the average of 16.9% across the nation. Last one I found interesting was that there was an estimated racial ethnic diversity score of 56 out of 100 for Miami in 2021. But that was compared to the average of 62 across the dashboard cities. And I found that interesting, very interesting. So we can explore that later. But I think what was missing, or maybe it was missing, as I looked at all the metrics on the City Health Dashboard, as well as an additional option to further investigate and analyze data, ability or disability was not listed. Or even if it was listed and I tried to compare or look at different outcomes, literally the quote came up on the website, no results found. And I found that surprising in 2023. And so though that is a serious concern, that's an opportunity. And I feel for Mailman, that's a big opportunity in terms of where we can reach out and try to address and target and work with these organizations. And there are other organizations, of course, that are collecting information. There are different surveys, right? The National Survey for Children's Health. There's also the Integrated Child Risk Index. They're collecting and reviewing data from several families, parent report and youth report for children with special healthcare needs, because it's important to inform and implement policy change. But I think from the first bullet, who are we asking to complete these? And are we missing anybody? And from which perspective? And what other factors are we considering? And I think that's important when we use data and collect data for whose agenda and per, what exactly is the goal or result desired? Or are we just making sure we ask the right questions to the right audience? So these are just questions I'm thinking of, right? Because I think when it comes to Mailman, and that's why I want to, definitely have a conversation, that's important. So that way we can inform, implement, shift, change structures and policies moving forward. So that was one piece on the importance of data, because this leads to now where I'm still keeping established and maintain infrastructure to advance equity. But I also want to hit on the next two, the first one and the third one, on embracing equity as the foundation of organizational commitments and communicating effectively, because that leads to training, right? That it's not just a domain, but it's actually how you do it, right? And so now this gets to us. And so my hope is you've seen the wording of that first bullet before. And so developing and implement training in health equity and evaluate outcomes. So with this priority, there are the 4 questions, and we're thinking of the 4 levels of outcome, right? Counts, or how's our counting of different concerns or different things, the individual reported benefits, the systems and capacity outcomes, and the actual population, the community, and how we're measuring quality improvement. Does this capture the feedback, this priority that's been provided to date when we implement different action steps? What existing capacity and programs support this? Instead of priority, I'm using the word urgency, and you'll see why I'm using the word urgency. And then what are the new initiatives Mailman is doing and nationally we're doing to support this urgency? And what are the resources needed to support this urgency? And so, Michelle, if you don't mind, I am going to stop sharing. I have no idea. I can't see who's in this Zoom right now until I stop. But I sort of wanted to stop here and just think about, where are we now? What are we doing? And what we need to do. And I'm just open to ideas because, again, I'm new here. I'm only 3 months in. And so I want to just open the floor. Whoa. I'm glad we have more people than when we started. Yeah, it's good. In terms of where are we going and just addressing those questions. And I'll again put the 4 questions in the chat so that way people don't forget. But I just want to open the floor. And I know you guys can talk. I know y'all can. I believe it. I believe it. Yes, I do.
Hey, Jennifer. So I was just thinking about how we were talking about intersectionality, but also the evaluating of that. And I find that in most of our research studies, even we silo different aspects of individuals' identity, and we don't actually show them in the way that they intersect. So it would make me, and even like in our national data, right? Even a lot of that is siloed, and you don't see like a lot of cross tabs where you can see how those various things intersect. Unless someone is intentionally looking at that within the study. So I feel like that might be like even like one of the starting points, at least from a data collection perspective, is how can we be intentional across all of our programs about collecting various aspects of intersectional identity that we know, right, are where there are health disparities, where we can be looking at least internally and programmatically of whether or not we're driving change or not.
Great point. Great point. And I appreciate the intention piece in terms of who are we talking to. So my question is, I know when I came here, I know we have different community academic partnerships we've built, which is fabulous. And how are we engaging? And I know you all have, because I've seen published work of what you've done. And so are there any other communities we're missing? And have we appreciated the voices from each of the, I know, 3 official ones that we're touching on? Who are we missing? So I was just throwing that out there too. Anybody else?
Hi, this is Hyro here. Sorry, I'm having lunch. What about
all good, Hyro? All good.
I've been asked by in the last year by Touching Miami with Love wants a representative, someone to come and we can share our resources down in Homestead.
Okay.
And I went there by myself, and you know, we got to get the word out there. And also I didn't have flyers in Spanish, and I don't know, there's a big Haitian American Haitian community there, but if there is, have Creole as well. That way, because I felt kind of bad. That's like I'm the only one here at my table, and I want to like spread the word. So that's a community that we got to reach out to, and they're right here next to us. But there's another one in Homestead, so they have like 2 bases there. So just wanted to share that as a suggestion. Thanks.
Thank you. Appreciate that. Who else wants to speak? Come on, don't be shy.
I think Valerie has her hand up.
Oh, go ahead. Hit it.
Hi, Jen.
Hey.
Thank you. So I have a question related to the intersectionality and I mean, all of what you presented on high school completion and so forth. And I was just wondering, is there data on literacy and healthcare literacy and those other factors in Miami or in the country, and how we compare? Because I find, you know, at least Miami-Dade very unique in the cultural mix and all of the other groups that people fall into, and literacy with written language, dialectical patois type languages, and how we can best serve those populations with all of those factors intersecting.
So valid, so valid. I think one of the resources where I got the data that relates to a future slide, I think it was called Florida Health Charts, does have a couple questions about literacy. And forgive my bias as I'm still new here, but I think back to the endowed chair I worked with back in Nationwide Children's, Dr. Dina Chisholm. She's done a lot of work around health equity. She's an endowed health equity chair. And so she hits on literacy hard, where that's a big, huge piece in terms of that can make a difference, which I think is a big piece we need to include in our plan. Again, I didn't read the full plan, disclosure. I'm reading a lot of it. Y'all have a lot there. I just want to let y'all know. I didn't read it fully all the way yet. Just give me work on it. But I know there are areas around literacy where I think can be huge, because I think that's a big piece for our parents and our caregivers, as well as other community stakeholders or constituents, I should use. That's very important that we need to include, and that intersects everywhere. Health literacy is a big piece. I know there was data in terms of even for kids, just even if they didn't really have an ability or disability status, how grades, how scores, very evidence that there were differences. And so that's a big piece. Totally agree with you, Valerie, totally.
Jennifer, I'm so glad you're here.
Thank you, Alan.
I really appreciate you bringing all these really important issues to focus, and it does align, of course, with our evolving strategic vision to advance health equity. It all can seem somewhat overwhelming. I'm sure everybody might feel that, you know, because when we get from the systems level that you're talking about down to the individual level where most of us work, you know, we can build in measures of health literacy. I've done that and published papers on health literacy and diabetes, for example. And I've looked in all of our individual areas, we can evaluate health disparities and things that may account for that. But ultimately, if we're going to affect change at a bigger level, I was really intrigued with one of the comments you made about to advance health equity, it really requires policy change. So I want to just have that on I think we really need to build that into our, you know, all of the works that we're doing with our IPCs, you know, to think about how depending on the conditions, we can look at autism diagnoses and late diagnoses and late at receiving services. We can do that with any number of individual groups of patients, obese patients, patients with diabetes, whatever it is, there's going to be those disparities. We already know it. But how can we think about implementing and addressing policies that will advance equity more quickly than the work we can do as individuals. I think we all are committed, to this as a priority. But I just want to encourage all of us at the IPCs, especially, to think about, well, how can we affect policy change? And I mean, one way to do it, and I did this with a group I was, another professional organization, Society of Behavioral Medicine, has had an emphasis on policy change as the focus of its mission, really. And one of the things that we would do when I was on the board, actually, we would do Hill visits in Washington, D.C. But one of the things that I think we maybe aren't doing enough of is visiting our local representatives. And that means for the state, legislature. Now that, granted, it's an uphill battle. And that this whole topic is an uphill battle in the state of Florida currently. But I think that one of the ways that we can advance equity best and more powerfully is through policy. So we should really be thinking about what are the policies that we want to see changes in.
That's fabulous. That's a great, so I will say, before I came back into town, I had the pleasure to be invited to a meeting, which I think sort of stimulated a couple of my slides, that involved how are we counting and refining our systems, how we count children and youth with special healthcare needs to inform policy change. So in this meeting, for example, I was the only DBP present, and there were policymakers in the room. There were heads of insurance companies in the room. There were other health commissioners and directors in the room. And there were a couple parents in the room of different race and ethnicity. And that led to an honest conversation of, when we count or ask specific questions. I remember a parent raised her hand immediately saying, you're missing an entire population of people you want to ask this question to, because they'll give a different answer, which then informs exactly, are we addressing a specific question on policy in the right way? Because policy change makers are asking for this information. It was the most amazing, mind-blowing conversation with all of us in a room for a day. And so that just led me to just really think, you're right, I don't know the Florida people yet. In terms of at the top, I know the opportunity will be coming, but where can we not just inform, but where can we build that relationship? So I know if there are trainees in the room or in the Zoom right now, and what Alan has brought up in terms of advocacy and going to the Hill, extremely important, totally important, highly recommend. Sometimes when you do that, that's the beginning of building a relationship, because then when you figure out what their interests are and how they can intersect and interlock and work, then we start having a relationship and then build and negotiate and make some changes happen. And I know this isn't Lend, and I know you guys are going to hit this hard, but this is important. So I'm so glad, Alan, you brought this up, because I just came from something like that, where I was in the room with policymakers and they were asking specific questions on, all right, if I give this survey or we forward this to the following people, are we even wording the questions correctly on the information you want to ask?
They require everything written, talk about health literacy, and a one-pager with key points. And because that's the only thing that's going to kind of stick with them. So, for example, Society of Behavioral Medicine creates health policy briefs, which are one-pagers, and which then we can distribute to the right people. But I guess that's one of the ways that we can be more effective in our advocacy with regard to policy change.
True. And if we're unified and make sure for us to Florida, because I know AUCD, I know you're right, they all do this. I want to go to the next step of when we're just in the room separate from that special day, where it can get sort of dirty. Not dirty in the sense, but like we get down and dirty on, this is what we're going to hit on and this is what we're going, because we got to be quick with our elevator pitch on what points we want to get across. Because Congress don't have a lot of time. State legislators don't have a lot of time. But no, that is a great point, because that's where I want us to go. And my hope is, yes, we incorporate this in the plan. We still got time. Does anybody else have any other questions or thoughts or comments?
I have this thought about when it comes to intersectionality,
yes,
and health equities, include the not only the risk factors, but the protective factors of the diversity within different groups of communities and cultures. Because that way we get the whole picture from a strength perspective, not just a deficit perspective, that counts for equity.
Love it. Love it. I love what you said. Perfect point. And I appreciate that we do need to collect that data. Absolutely. I think building on this, I think depending on who you're presenting info to and what audience you're presenting to, I think it's just a matter of strategy and just thinking, you know how in an IEP, in an individualized education plan, sometimes you want to make sure you hit on the deficits at a good level so we know we can get the services for the child. Because if you hit too much on protective factors, depending on who's reading that, they may say, then why do I need to give services to this child? You see what I mean? Like, I think it's important to collect that data, but then how you interpret and deliver the results, depending on the audience you're going to, that makes a difference too. Because we want to make sure we get that information and get it right and get the result we need. But I love your point, and absolutely, we need to collect it. And when we screen every kid, actually in primary care, we should hit on risk and protective factors and document it both. You're totally 1,000% correct. Any other thoughts?
One thing that comes to mind for me with
Yeah.
strength is like, hey, is the strength of the community where a lot of these families live. And I think like working on the youth PCAT's like and coach projects, I've really gotten a good feel for that from a lot of the providers in the community that actually have a lot of awesome things that they're doing and that they want to do.
Ooh.
But and the people, the biggest thing is that the community members trust these community organizations. So it's a way to support them and empower them and connect them with each other. That's not us as a university saying like, hey, here's the solution to the problems that exist in your community. It's more like, hey, how can we help you? How can we make your influence reach more people in your community doing the things that you know are important for health equity? And I think that shifting that perspective is hugely important.
Love it, Abby. And would you then recommend, even before, you're right, in terms of we shouldn't just come and say, here's the solution. The community, whoever is going to represent, needs to be present from the beginning, when even the thought is made, when even the problem is even identified and clarified, that perspective should be there front and center from jump, right?
Yeah.
Exactly. We got to make sure to remind ourselves to do that. Means I'm including myself in this. Yes. Who else we got? Appreciate it. Love the inner. I love this. This is good.
Well, as everybody's been talking, I am thinking about our strategic planning, and as I've been listening to the discussion, what came to my mind is that we've identified this overarching aim for advancing health equity, right, at the intersection of disability. But we've also identified two other areas at the present time, one around the idea of community-based participatory principles, right? How can we engage our community and develop those partnerships?
Yes.
And then the third around innovative technology. So, we've talked about the fact that there are limitations in our data systems and where we're collecting the data and how we're collecting the data. That actually came up in the paper that you were referencing with the work that we're doing with community academic partnerships. That was one of the limitations of our findings, was that we were limited in the data that we could present based on the systems that were available to look at the data, right? So as we're looking at the strategic planning, I think we also need to look across our aims to see how they can help support each other, right? So how can advancing health equity, community-based principles, and the use of innovative technology to develop better data systems, right? So that we can collect the information from the populations that we're targeting and that we're doing it that are representative of the communities that we're working on. I think we need to think about how each of these aims support each other in advancing the work that we're doing at the Mailman Center. So it just made me think about how I don't want to look at these aims as silos, right?
Correct.
And
Correct.
how could we use them to work together and help support each of the different areas?
Love that. When you were hitting on systems in terms of the systems we have, because I think that was one of my questions. And I know I need to do a better job of engaging, and I know certain people on this call are going to help me look at certain systems. But I think that's the thing within the systems. Are there pieces or questions or how we're asking questions? Do they need to shift? So that way we're gathering the right information from parents and communities appropriately. Like, that's just something that came to my mind.
Well, that's a good question, and I hate to put Jason on the spot, but
I
I know that when we're thinking about, so because we're currently using data systems that are publicly available that we have access to, right?
Right.
But they're not, as you mentioned in your presentation, they don't include the items or the things that we're particularly interested in or the things that we want to examine. So it's almost like we have to think about how to create our own data system that would be, and that, again, I'm not speaking from expertise here. I'm just brainstorming. That's why I was gonna call on Jason, because I think he knows this area a little bit better than I do.
Right, right. Before Jason, Dr. Armstrong's hand is up. Hit it.
Yeah, thanks. And Jen, this is really good. I think you raised a point early when we were talking about literacy, about understanding the community. Abby's point is really an exceptional one. Our focus and our commitment 7-8 years ago to working with communities was really based on not having us be the ivory tower that brought information to change the community, but to really partner with the communities to help them to identify what were the areas that they were struggling with, that they couldn't deal with on their own, that we might be able to come in a collaborative way and help them with. Miami-Dade is an incredible laboratory for health equity, but it requires phenomenal nuances. You know, when we talk about literacy, we talk about, you know, Val's question was a really good one, but, you know, the question is, we've got 28 different countries of origin where Spanish is the language, but they're not the same. It's not the same Spanish in all of those areas. We have multiple generations which change and affect the use of language. When we think about language, we often think about, can they speak conversationally, but that doesn't mean that they necessarily can read or write or speak in that language. And there's subtle differences that occur across that whole range. So we just take literacy, the intersectionality around literacy is just so complex that it's impossible, and it is constantly changing. We tried to do a acculturation study 15-20 years ago, with the concept being at the time that acculturation was how someone from a minority culture adapts to a majority culture. And the problem we had was we couldn't define the majority culture in Miami because it is so complex. But I think the other piece to Abby's perspective, and I wanted to really highlight this, is it's not only what we bring to help build community capacity. I do think helping communities to be able to identify and gain the skills and resources to address their own needs is important, but the amount that we learn from the communities. I mean, we've chosen to work with 3 primary communities that are quite diverse: Overtown, East Little Havana, and the Northeast Corridor. And we're working very carefully and quietly with developing relationship with the Miccosukee tribe, so that we're dealing with the tribal nation. Those are countries in and of themselves in those communities, and each one of them has a different set of needs, a different perspective, culturally, linguistically, and on a whole host of other dimensions. Looking at that, and so addressing health equity requires us to have very broad minds. But the challenge for us is having such a broad mind that we can't focus on anything that's meaningful. And so to Michelle's point, that's really where tying all the things that we're doing in our strategic plan together is really essential. And what you've talked about today is really a nice driving force for helping us to get there. And this conversation that everybody is bringing in, I'm really appreciative of. So thank you.
Thank you for your thoughts on that. And appreciate that. See, this is why I'm excited, though I'm 3 months in and learning how amazing this community and this whole county is. And I appreciate other organizations on here. I see Early Steps represented. And so that's why I'm excited for this. So this is good. And we're doing well with time, you guys, because I don't have a lot of slides left. So we'll be done on time. That's why I did this on purpose. I wanted to make sure there was discussion on this. But there's so much at play. My conclusion slide is going to get to this because I think sometimes this feels quite daunting. And overwhelming, but it's possible. This is not impossible. So let me bring my slides back while if anyone has final thoughts, and we're going to keep it moving and we're going to end on time. Don't you worry. Let me minimize this to do this. And get this. And go back to this. All right, almost there. Here we go. And this and this. Okay. I think you see my slides again, right? You do?
We can.
Okay, good. Okay, good. All right. And so, but I've appreciated this conversation and I'm excited at how committed we are. And then you also see I changed the word from priority to urgency in this presentation. And you may wonder, you probably know the answer though, why the urgency, right? Why the urgency? Because our children and youth are not okay. They're not. They're not. And it should be a concern, and it really should be an alarm. And I think we all know this. And so have to bring in the data, of course. So nationally, this still is applicable as of this past July. There are 19 million children living in this nation who have a special healthcare need. That's a lot of children, 14 million children. That specific percentage, we're not far off in Florida, it's 18.6%. In Florida, of children have a special healthcare need. And nationally, slightly more common again in non-Hispanic Black children and children living in poverty. That's a big issue too. Again, speaking to the intersectionality of all these different factors, right? And then 36.3% of children with multiple ACEs have a special healthcare need. But you know, ACEs don't come out of the sky, right? They came from somewhere. And so that's an important point. But that's why how urgent this is. And then speaking to poverty even more, this month, the data brief that just came out this month has a focus on poverty and material hardship, the inability to afford basic needs, parents reporting difficulty covering food, housing, family income. That's a lot of children. 31.9 million children in this nation are experiencing material hardship during their lifetime. And then think of really who of course is at the highest of this group of children. It's actually technically for stats, American Indian, Alaskan Native, the original tribes, Native Hawaiian, other Pacific Islander, then Black, then Hispanic, then multiple race, that's 43.1%. Then white, 38.2%, and 29% Asian. So I just want us to notice just the intersectionality in the current numbers from these past couple slides and the overlapping categories and how, yes, daunting a lot of this information can be, but we have to appreciate and validate the lived experiences of these families and their perspective. And it's important to keep that in mind when we think about the last domain, right? Which is embody anti-racism and anti-oppression in all aspects of the organization, in our communities, and our interventions. That's interesting. Note the word embody. And I think we know this, not just know it. Don't remember, like we have to talk about it, but we live it, right? We got to do the work. Do we check our bias? Do we check our mindset? Do we check our bias when we're with a patient? Do I check my bias when I'm about to talk to a community group on specific topics? Do I check my bias when I go to the grocery store? Do I check my bias when I'm in road rage? Right? I mean, like that's how we have to think about it. And forgive me, I don't do a lot of road rage. I try to behave. But that's important, right? And so I think at the end, and that's why I was excited to move down here, because I always love appreciating and learning different aspects. And when we think about the word inclusion, right, or the term belonging, we know that requires something, right? And that requires us addressing the isms, right? Are we addressing and aware of the range of attitudes and behaviors that involve perceived superiority, oppression, prejudice, and discrimination? And are we understanding and responding to multiple cultural identities and intersectionality? And I could add another 5 circles to the 5 that are there, but it requires that we do this, that we have to address that, right? Are we welcoming those who are historically not welcome to come in? Because, right, who has the authority or right to invite others in? How did the inviters get in? Who is doing the excluding? It's our responsibility as a society, as a mailman, to remove all barriers which uphold exclusion, since none of us have the authority to invite others in, right? We're recognizing that we are one, even though we're not the same, and it's beautiful and it's great. Because if we all were the same, it'd be boring, okay? So we gotta appreciate that. Because once we do that and really require that, we know we'll have achieved it. The work environment, the everyday environment, everyone is treated fairly and respectfully, equally accessing opportunities and resources and contributing fully. And that every voice, perspective, experience, lived experience from individuals with IDD, from the families of these individuals, from all backgrounds, underserved or historically marginalized or systemically excluded, are heard. And so, as we stated before, there were moments where, of course, again, this can be daunting, but it's not impossible. So in the words of Muhammad Ali, impossible is just a big word thrown around by small men who find it easier to live in the world they've been given than to explore the power they have to change it. Impossible is not a fact, it's an opinion. It's not a declaration, it's a dare. Impossible is potential. Impossible is temporary. Impossible is nothing. I want to acknowledge all these people who have been along with me on this journey, who I've learned from, acknowledged from, including people from within this Zoom, and definitely the children and families I've interacted with, as they've been a joy and they've taught me so much. I told you I'd end on time, if not early. I will stop sharing. And so this leads to any final thoughts or questions or comments or critique or, whatever we desire. But I'm hoping, and what I hope, Michelle, Jason, Dr. Armstrong, and really everybody here, as we think about our strategic plan, I wanted this to be the starting point. So now if we call a meeting to discuss the next steps, that we continue this conversation and then build more action steps. So when I report back to the steering committee, whenever we have these talks, that we're starting to truly make next steps on advancing health equity and cross-cut the other priorities at the Mailman Center. That was my goal for this talk. If you bring me back for another talk, it'll be on something different and like something specific. I think go from there. But that's what I hoped from this talk initially. Any comments or critique? I'm down for whatever. I'm always here to grow.
Thanks very much, Jennifer. Look forward to working with you and seeing you at more of these meetings.
Excellent beginning conversation. Excellent. I loved it.
Thank you.
I'm just going to throw it out for the trainees on the call. There will be an opportunity to serve on these work groups. This being one of the 3 work groups that we'll have. So if this is a topic or a passion for you and you're interested in being involved, we'll be getting out some information to the various discipline supervisors over the next couple of weeks. So you have an opportunity, and then we'll work with your rotation supervisors to get you some release time to actually be able to participate in the work groups when they happen.
Excellent. Well, thank you so much, Dr. Walton. I really appreciated the interactive nature of this grand rounds. It really made it stimulating and engaging. So thank you very much. We appreciate it. And with that, happy Friday, everyone.
Enjoy the weekend, everybody.